I'm the director of the Vermont Citizens Campaign for Health. Peter Sterling is the director of the Vermont Campaign for Healthcare Security, also the director of the Vermont Leads, which is Vermont's newest single-payer organization. Peter and I have been working for a number of years on healthcare reform things in Montpelier and activism and those kinds of things. Peter has the ability to explain very dense, arcane political stuff and help people understand it. So that's why I dragged him down here, because he's really good at that. Plus, he's on the inside, and he's spending almost every day at the State House in Montpelier, and he's up on what's going on, and he's a great source of information. So I asked him to talk about, help people understand the exchanges, that the federally mandated exchanges are coming to Vermont in 2014, and a lot of people, hardly anybody understands anything about them except for a few people like Peter. And he's also going to give us an update on the single-payer momentum in Vermont. So that's enough of that.
That's great. Thank you, Richard. No. Well, thank you. Well, first, let me say I'm going to talk a lot about some arcane aspects of the Affordable Care Act and the exchange, and mostly how they relate to people and their need to access health care. So I will bring it down, but I do have to say that Richard taught me something, said something to me when we first met way back, and he said, Peter, this whole healthcare thing, it's all political. And it's really true. Anything that we talk about, any of the problems we talk about today, there's a solution to every one of them. And so if it sounds hopeless or bad, I just want to remind you that we can change anything, and there's nothing that cannot be changed to basically ensure that people can get access to affordable health care. So right now, everybody, if we could just, I'll run through what the healthcare exchange is and isn't. You should be looking at this sheet and how it relates to what we all believe, I think we all believe, is the ultimate solution, which is a universal, publicly funded, single-payer healthcare system. So a few years ago, the Congress and Barack Obama passed Obamacare, which actually I think is kind of a cool term. People say you shouldn't use it. But the main thing that will do is create healthcare exchanges. And that's what I want to explain. So in January of 2014, all Vermonters who are not getting employer-sponsored health care will have to buy their insurance through this healthcare exchange. Small businesses with less than 50 employees will have to buy their insurance through this healthcare exchange. That's about 100,000 people are going to see radically different health care as a result of the Federal Affordable Care Act. So what is this healthcare exchange? So let's look at that second bullet. The exchange will contain an estimated 20 to 30 private insurance plans. I'm going to repeat that because that's really important. The healthcare exchange, even though it's government healthcare, I know, right? Let's all start shaking our heads now, and we'll just keep going for the next half hour. The exchange is essentially a cluster, a group of 20 to 30 private health insurance products that's heavily regulated by the state of Vermont. And I have to get this irony out there right away. So for those of us who follow the debate and now about how Obamacare is socialism and government run amok, Catamount Health and VHAP, two publicly funded health care plans, Medicaid expansion programs, are going to be eliminated when the exchange starts in 2014, and most of their enrollees, like me, and I'm in Catamount, I will have to go into the exchange and buy a private health insurance product. So when we have, the crazy uncle or, not crazy uncle, but the reactionary uncle at the holiday gathering, and they talk about government-run health care here and the exchange, remind them that you can think of about 30,000 Vermonters who are going to lose publicly funded health care and have to go buy private insurance in the exchange.
I understand you correctly that the Medicaid people who are currently Medicaid recipients...
I'm going to get to Medicaid in one moment, if I can. I try to go in an order here so it's logical. It builds on each other. So what we've learned is there's about 100,000 Vermonters who are going to go into this exchange, which is a group of 20 to 30. We don't know exactly how many yet, private insurance plans. The third bullet, this is actually, I think, a relatively good thing. And this shows you how underwhelming the exchange really is, if this is one of its high points. The benefit package of these 20 to 30 plans are all the same. They'll have a common benefit package. So as a person, if you need to enroll in the exchange, you're not going to have to worry, well, is a mammogram covered in this one? Or can I get my tamoxifen in this one, my prescription drug in that one? It's a common benefit package. What will differ in the exchange is cost sharing, meaning your monthly premiums, your deductibles, your coinsurance, all those amazing artifacts of the private insurance market. They will be right there for you. Enrollment in the exchange, it begins in October, and coverage will be in January. And if you look at, there's an open period for individuals, which ends March 31st, 2014. So let's say I am your carpenter, and it's been a tough winter, and I don't have any money, and I'm uninsured. But April turns out to be a great month. All these bills got paid, and I want to enroll. I will not be able to enroll in the exchange because it's after the open enrollment period. I will have to wait until January of 2015 to get health insurance. So, it's a very, very bad thing, this open enrollment period. There are going to be many people, I believe, who, for whatever reason, will not get it together to get insurance by March, the end of March, and then will be frozen out of insurance. Now,
No exception?
well, not if you're uninsured. If you lose your insurance after March, then yes, you can get insurance. If you get fired, you get divorced, then you can enroll in the exchange. But if you're uninsured, as an individual, after the end of March, you cannot go into the exchange until the next calendar year. So we're now on the 6th bullet there. People. Good reason. In Massachusetts is the only state in the country that has this kind of this model with an insurance mandate, and what they found was that people were not paying they didn't have an open enrollment period. People were not paying their premiums until they got sick, and so this is a way to force people to pay premiums. I think it's maybe, it seems kind of cruel, to be honest. If they can't afford it, they can't afford it. But people were not paying their premiums until they got sick, and this was the way to compel them. I would argue that if premiums were truly affordable, people would pay them, and you wouldn't have this problem. And the problem with the Massachusetts model and the exchange is when you're asking someone making, say, $25,000 a year to pay an insurance premium of $150 a month, they have to make very, very basic decisions about their life. Can I fill up my heating tank with oil? Can I get my crappy car fixed? Because, when you don't make a lot of money, you're usually not driving a great car. That's been my experience, at least. The good cars come with more money. And so it's kind of a backwards way of enforcing what you want. I think instead of making healthcare affordable, you punish people for not doing it, which is not the way we should be going. But that's federal law, and there's nothing we can do about it. People whose incomes are between 134% and 400% of the federal poverty level will receive premium tax credits to help lower the cost of their premium. That means people who are making roughly as a single person, between $15,000 and about $43,000 a year will get a federal subsidy in the exchange. And I'll go into some specifics when I'm done with these bullets about what that exactly means. People whose incomes are between 134 and 250% of the poverty level, that's roughly that $14,000 a year up to about $25,000 a year, will also receive federal cost-sharing subsidies to help lower their deductibles, co-pays, and things like that. Here's some good news about the exchange. Anyone whose income is under 133% of the poverty level will be eligible for Medicaid. So currently, if you're a childless adult and you were making, let's say, $10,000 a year, you would not be eligible for Medicaid because there's categorical exclusions, meaning you would have to either be disabled, blind, taking care of a blind person or disabled person, things like that. All those categories are gone, and Medicaid eligibility will be based purely on your income, which is wonderful because Medicaid doesn't have a premium, it doesn't have out-of-pocket costs, and although it's by far from being sufficient, it does have a $490 adult dental benefit. So we are going to see thousands of people in Vermont who are now either in Catamount or VHAP with premiums and deductibles go into Medicaid. And I'd like to literally step back for a minute. And while in Vermont we have done so much, we have done more than almost any other state to extend publicly subsidized health care to childless adults. Other states never did this. You know, for example, if you live in Tennessee, as a childless adult, to get into their Medicaid program, you have to have less than $2,000 in annual income and assets. Basically, you have to be homeless. You have anything, a car, anything, you are not, I mean, they basically have said to childless adults, there is no public health care for you. So because this federal law is kicking in, you are going to see tens and tens of millions of Americans who make below $15,000 a year now get a public health care program, which is really a wonderful thing. Granted, in Vermont, it's no great shakes because we've been doing that since the creation of VHAP in, the mid-90s. So, yep.
Do you have a sense of about what percent of the people who are currently on VHAP or Catamount will be under that 130?
I do, because I'm such a dork. I actually spend all this time memorizing it. There are, gets geek, I should say geek? Okay, I'll say geek.
Either way.
I'll get you the exact.
In the grandson of your geek.
All right. There are 36,000 Vermonters in VHAP right now. 80% of those will go into Medicaid because they're under 133% of the poverty level. So that's good. That means no premium health care for them. There's also, of the 11,000 Vermonters on Catamount Health, roughly about 1,000 of those will go into Medicaid as well, which means about 10% of the Catamount Health population. So that's a lot of those people will see an increased benefit for significantly lower costs. I mean, free health care for them. So let me just say, importantly, Dr. Dinosaur and Medicare remain unchanged when the exchange starts. There's no changes to the Medicare program, its eligibility, or Dr. Dinosaur, which is good because, well, Dr. Dinosaur seems to be working. We don't want to touch that. In the exchange, all pre-existing condition exclusions and waiting periods are eliminated. So right now, let's say if you are in a high deductible plan and you just can't afford it, you have a $5,000 deductible, you can't afford it, you're a carpenter, you drop that plan, you cannot go right into Catamount or VHAP. You have to wait a year. That was courtesy of Jim Douglas, putting a year waiting period on that. If your employer drops insurance, and even though it's no fault of yours, you still would have to wait a year to get into Catamount or VHAP. Those waiting periods go away. I mean, of course, they are replaced by the open enrollment period that we talked about. But beginning in 2014, there is an individual mandate for purchasing health insurance. The penalty starts out relatively small. It's about $90 a year. And I was making a joke today when I was having lunch with someone that it would be like if you owned we were at the Blue Moose. Imagine if you owned the Blue Moose restaurant and the government came up with a mandate that everyone had to eat at the Blue Moose. Yet some people are going to be getting public tax dollars to subsidize your meal at the Blue Moose. If you own the Blue Moose restaurant, you would be a very happy person. And that's what this exchange is for insurance companies. There's going to be a mandate that everyone buys private insurance, and we're going to use public tax dollars to subsidize millions of people to buy those private insurance products. Does everyone get that? I mean, to me, that's like the basis of what we're talking about here. Public dollars are being used to subsidize people to go into private insurance products. So if you have the opportunity, go out and start an insurance company before 2014. That would be my advice to you. Employers with fewer than 50 full-time employees are able to drop their insurance and let their employees go into the exchange and not have any penalty. So let's say I work for a construction company with 40 employees, and I give them all insurance. I drop that insurance. I pay no penalty as the employer. All my employees can enter the exchange, and most of them, because they're not making probably over the federal limit for the subsidies, will now get government-subsidized health care. And let's say I'm a benevolent employer. I could say, you know, Richard, you've been with me a long time. I'm dropping your insurance. I'm going to pitch in $100 a month toward your health care premium. So I'm taking advantage of the federal subsidies, and I'm helping my employee out even more. And this is a great deal for employers, I think, if they're under that income threshold to receive the public subsidies, which 80% of Vermonters are. I mean, very few Vermonters are, let's say, in a family of four making over $95,000 a year. So to me, if you're a small employer, this exchange is a great deal. You go back, you can concentrate on your business, which is construction, making widgets, whatnot. Your employees go into the exchange. No longer is their health insurance related to whether or where they work, so it goes with them if they have a seasonal job or not. They leave you at the end of the construction season with insurance, and they come back with insurance. And the government's subsidizing their care. I mean, it's never really, even though I study this a lot and I talk to a lot of people about it, I've never really understood why businesses are opposing this. I know it doesn't pass, I know. And here's another part, and then I really will answer questions. What I just talked about was for businesses with less than 50 employees. If you have more than 50 employees and you drop insurance, you do pay a penalty. But you only pay a $2,000 penalty on the first, well, let me say it the other way. You pay a $2,000 penalty on every employee in the exchange, but the first 30 are exempt. So, to break it down for you, let's say I have 100 employees, and all 100 go into the exchange when I drop my insurance as a business owner. I only pay that $2,000 penalty on 70 employees. The first 30 are exempt. So for $140,000 a year, I am now providing insurance, essentially, for all 100 of my employees, which is a lot cheaper than actually paying an insurance company for it. And it's better quality because they're in the exchange, and there's relatively low deductibles compared to outside the exchange market. So even if you're a large business, paying that financial penalty is a way better deal than providing your own insurance. So again, I'm not really sure why, other than philosophical opposition to government health care, anybody would not drop their insurance, which really moves us closer to what I think many of us believe in, which is getting everyone into one big collective government-run pool, which will transition us to single payer. So those are the highlights or lowlights, as I like to think of them, of the exchange. And I have more I'd like to talk about, but I really would love to answer questions. Yeah, Maggie.
Small business. I know several people who have small businesses, and say for one example is a carpenter who has say half a dozen employees. All of the spouses work. And so the guys working in the carpentry business are covered under their wives' insurance. And what should they do? I mean, that's a situation which will make some questions be asked when this.
I mean,
It's common.
That's very common, actually, for small businesses to rely on people outside their employment to give insurance to their employees. It will all depend on what those spouses' insurance come from. If they come from group plans that are in the exchange, then these people will go in the exchange. But if they work for a big company, like let's say IBM, who's going to hold on to their insurance, then probably nothing will change. So in that situation, the employer is really, he's still out of the game of insurance, no matter what.
Is this whole list of federal mandates?
That's a great question. Yes. Well, everything is federal law except for the number of plans in the exchange. That is up for each state to decide. That second bullet there. And let me say, as someone, part of what my organization, the Health Campaign for Healthcare Security, does, what we've been doing for 6 years is we run a consumer helpline. We do public talks to help people enroll and help them through the process. And, I'm not saying, people get very confused by the process of enrolling in healthcare. And I have to be honest with you, the fact that we have an essential benefit package in the exchange, meaning every benefit package is the same, I am not sure why we need to provide consumers 20 to 30 choices in cost sharing. It's beyond me. I think, quite honestly, if we had 3, maybe like a $500 deductible, a $750, and $1,000, I believe that would meet most people's needs as far as like a premium level. 20 to 30 is going to be very, very difficult to explain to consumers because I've seen the details of many of these plans. And I mean, forgive me if this is too technical, but like one plan, they look so similar. One plan has a $20 copay for specialty visits, like physical therapists, but a plan that's right next to it has a 20% co-insurance charge on that same. So how are you going to explain that to a consumer? I mean, it's going to be very difficult, and I'm not sure the consumer is actually served by having that many choices. I believe it's mostly done to, quite honestly, help insurance companies. and so that part is up to Vermont. I wish there were fewer, and there's not going to be, so that pre-roll planning for it. And one of the things that we had advocated for was a really active public entity that could help educate people about these plans. But the state has this contracts with this private company called Maximus to answer all consumers' questions, and they really fail miserably. As a basic example, they are open from 8 to 4:30. And there are many people who have questions about healthcare who have to call after 4:30 because they're on a job all day. And so you cannot get your phone call answered after 4:30, which is ridiculous. A lot of times they have people who are not, not as highly trained as they can be. Like, for example, one of the great nice things about Catamount is if you are on Cobra, you can get off Cobra onto Catamount. And we've had many complaints of people calling, and there's a reason I'm telling you these anecdotes. Call up Maximus and say, I'm on my employer's health care. They think Cobra is still part of their employer's health care. But if your employer's health care, you're not allowed to be on Catamount. But like when more highly trained people do it, like I pay people a lot of money to answer these phone calls, we get to the bottom of it. We figure out they're on Cobra, and we get them off of Cobra onto VHAP or Catamount, and they save a lot of money. The reason I mention that is the state of Vermont currently does not do a good job educating people about their options for public health care programs. Under the Affordable Care Act, it's supposed to be different. There's federal money coming in, actually probably $2 million in 2014 to set up systems where consumers will be able to go talk one-on-one to people who can help them. And one of the processes is called a Navigator. And who will be a nonprofit entity, in theory, like an organization like mine, that would actually be on the ground to assist people in enrolling. I have to be honest, I tell you those anecdotes because I'm not entirely sure that Navigator system is going to work as well as it should. When you're talking about 100,000, there's going to be 100,000 people, that's probably like 20,000 people, making decisions on healthcare. A mother might make it for a family of 4, that kind of thing. Like 20,000 people are going to need information in a very short time period over about 20 different plans. Like the current system with Maximus and nonprofits like me are overwhelmed talking about Catamount, VHAP, and Dr. Dinosaur. That's 3 plans. So I'm very nervous about this whole public education apparatus that's being set up. I mean, I hope it works, and I hope it works. And I'm not sure that much is actually going to change. I have to be honest.
At the table in Williston at
Yeah,
this exchange?
I am, and it's a very, what?
Are you influenced?
I will give the governor credit. I'm not going to give him credit for too much tonight. I'm not going to lie. But I will give him credit for hiring very, very talented people to implement this exchange and to implement single payer. And they are trying, but there's a lot of bureaucracy involved with a lot setting up this exchange. I believe the state's going to do the best it can to implement this exchange, but I'm very nervous that the Navigator processes will not be enough to reach a lot of people. I mean, as we all know, we go around our lives, you meet a lot of different people with a lot of different levels of literacy. A lot of people have a hard time handling forms. This is essentially, right, this exchange is private health insurance. You're still going to have to fill out applications. Like, that is not good for a lot of people who get frustrated. You're going to have to provide your taxes, right? What happens if you lost your taxes? You didn't get them done in time. Whatever. You can't get health care. That's not good. So we're going to work on it, but I have to admit, I will be much happier in the end of 2014 when 100,000 people are enrolled in this and there's not a lot of public turmoil.
Could you explain what you just meant about if you lose your taxes, you can't get health care?
Well, you have if you don't file taxes or
you don't have those documents.
Right. Everything in the exchange, all the premium subsidies and things like that are based on your taxes.
So that's a barrier.
Yeah.
That will be a barrier
exactly.
for people to getting supposedly
Right.
universal health care.
Oh yeah, there's no doubt. And this is actually a fairly unbelievable part of the exchange, but it actually is true. At the end of the year, everyone who's received public dollars for a subsidy undergoes a process called reconciliation. So let's say I'm going to apply for the exchange, and I give the government my 2013 taxes, and they base my premiums on my 2013 income for 2014. So at the end of 2014, when I do my taxes again, they're going to look at my taxes, and if they've found that I actually made more than in the last year, I'm going to have to pay the government back a lot of that money that they gave me. So you're talking about Vermont, it's called reconciliation. So you could pay back thousands. So some Vermonter could get a bill at the middle of 2015 saying you owe the United States government $2,000, $3,000, $4,000 for payment on what we overpaid you for your 2014 health care. Now, that does not sound good to me, and that's federal law, and there's nothing we can do about it. There are limits to how much you should have to pay back, but I will say that the eligibility for the premium subsidies is 400% of the poverty level, about 85 grand for a family of 4, roughly. If you go $1 over that 400% of poverty level, you have to pay the entire subsidy back. Even if you lived 11 months of the year under that level, you had a big December, you work at UPS, you got a lot of overtime because it's Christmas, you go over that because of that 1 month of a big pay, you got to pay it back. I know it's really bad. It's going to be really bad for people who don't have a lot of cash on hand.
What happens if they don't pay it?
Well, it's just like not paying your taxes. I mean, that reconciliation process is probably the one thing that most keeps me awake at night, is the thought of, because most people, are not going to think, oh, did I go over 400% of poverty level this month? Should I be banking extra, should I be saving money? They're going to spend their money, because that's what you have to do when you don't have a lot of it. You have to pay bills and stuff. And so they're not going to be thinking each month, oh, am I going over, I should bank some. They're just going to spend their money thinking they've got affordable health care, and then they could get hit at the end of the year with this, and that's not good. And then you, Maggie.
It's just, I'm still trying to grasp this.
Okay.
So is it in any 1 month if you go
No.
over 400%?
No. If at the end, if your annual, if the
end
income
of
you
the
declare in
year,
your
if you-
taxes, but what I was trying to illustrate
Right,
was,
I get what you're, yeah.
okay, so you could be very poor for 11 months.
Right, and in the last month. you
December,
get-
get a lot of money, and then that would boost you over the eligibility level for the.
And then you have to pay back your whole.
Yes, as if you had lived all 12 months.
On that, yeah.
Yes. Yeah, I know, that's lame. Yep.
Oh, my question has to do with the premiums. Now, the federal government is saying that the premiums that Catamount and VHAP pay, that's not enough, that under these new plans,
Right.
you have to pay more.
Right.
And that's a federal law. Now, if, for example, we were only paying what we were paying VHAP and Catamount, would these private companies still making a profit? And with the increase, are they making more profit? Do we have that information?
Yeah, that's a good question. I don't know yet. I really don't. I know what the per member per month costs are supposed to be for Catamount and the administrative costs that are built in, and we know that for VHAP. I don't know. My guess is most insurance companies are probably designing their products in a way that they will make some money.
They've been jacking up premiums like crazy.
Well, let me just say is that it's a good time to segue to the chart on the other side of this, if I could. What it is the Affordable Care Act does limit how much individuals under certain income levels pay in premiums. So, for example, if you are at, let's say, 150% of the poverty level, that's like $1,400 a month gross, the Affordable Care Act says you can pay no more than 4% of your monthly income, or $56 a month in premiums. So that means even if the insurance companies jack up the rates, your subsidized costs will stay the same. So, but the thing is, they're going to just charge the government for that money. The government's going to pay the difference. So it's still not good. So this is what Maggie's talking about. So if you look at that first line under if your household income is, that's a person who's making $17,000 a year. That person's on VHAP now, so you can look at that middle column. They pay annually about $400 a year in premiums, or about $33 a month. And there are a couple prescription drug copays, so probably on the hook for tops $200 more, so $600 a year, which, is still a lot of money, but, passes the straight face test. The column on the right, that person's premiums go up, and look, they now have a $600 deductible. Okay, let me just say, this column on the right, this includes a subsidy that Governor Shumlin put in his budget. If I would read from this chart that I made before the governor announced his budget, that same individual, and this is not a typo, would have paid $684 a year in premiums. Remember, they're making 17 grand gross, and everyone raises their hand who pays their bills out of gross income. Yeah, you don't, right? And their out-of-pocket limit was $250. So all told, if that person got sick who made 17 grand, they would pay $3,000 out of pocket before their insurance essentially kicked in. Okay? That's when the ACA says the governor has tried to mitigate that sum, but clearly it doesn't go low enough. And I'll cite one more example, and then we can talk about this. If you look at the couple who's making $46,000 a year, right now on Catamount, they pay a lot in premiums, which is about $5,000, but their out-of-pocket limit's relatively low at $2,100 if they were to get sick. Under the Affordable Care Act, their premiums would go down a little bit to about $3,700. This is on the old one. And their out-of-pocket limit, however, is $12,800. So that couple, before the governor acted, would have paid $17,000 a year if they were to get sick out of their $46,000 income. The governor has tried to buy down that. This is the old chart. I'm sorry, I have a chart here that was before the governor made his proposal in his budget to buy down the cost of this. I'm just saying the Affordable Care Act wasn't so affordable for a lot of people. But the governor, even with his effort to use state dollars to help make this more affordable, to me, a couple who's making $46,000 should not pay almost $9,000 in costs if they were to get sick. So, granted, does everyone reach their out-of-pocket limit? No, of course not. The statistics are about 30% of the people in this population are likely to hit their out-of-pocket limit. But it takes one illness, and what happens if you're sick in 1 year and then you maybe put on the credit card, or if you're lucky, a home equity loan. The next year you get sick, you got to go do that again. This is not a one-time deal.
And don't get sick in December
right.
And have it go over
right.
to January.
So the point of this chart that I'm trying to illustrate is that the limits set by the Affordable Care Act for premiums and out-of-pocket costs, even with what the governor has proposed in his budget of a few weeks ago, still does not go anywhere near enough to make health care affordable. And I will say this. Richard, my opening remark, how all this is political, the current cost sharing of Catamount and VHAP, in my mind, do not work. Half the uninsured are eligible for VHAP, Catamount, or Dr. Dinosaur. Okay? We have 21,000 Vermonters who could enroll in Catamount, VHAP, or Dr. Dinosaur and don't enroll. Why don't they enroll? Every year the state does a survey. Every year they find the same thing. About 75% of Vermonters say cost is the #1 reason they're uninsured. And because I have a chart that even shows it, in case you don't believe me, let's see if I can find it. I'll pass it around. It's the same chart, but 61% of Vermonters said cost is absolutely the only reason they don't enroll, and or cost is one of the main reasons they don't enroll. And so if we know cost is too high right now for Catamount and VHAP, yet we're going to make it more expensive, clearly we're going to add to the uninsured population. So if I were able to write the state budget, I would have said you should probably at very least cut every Catamount and VHAP premium and out-of-pocket costs in half. Maybe people would be able to afford it then. But certainly increasing it's only going to drive up the uninsured. I did not feel in a year when they're cutting $70, $80 million from the budget, I could walk into the State House and say anything but, please at least hold people harmless, don't do damage, don't move Vermonters backwards by increasing their out-of-pocket costs. So that, I felt like I had to go in there with a political solution that was feasible, and I'm not happy about it. But when I talk about how we should hold people harmless, that's probably the best we could ever have hoped for. And I will say something interesting that I learned when I was reading through this huge study, which if you're really interested in what Vermonters are thinking about healthcare, it's fascinating to people like me. It's very common that we think, or we're told, that the uninsured are the young and invincibles. Has anyone ever heard that term? Like the 18 to 24-year-olds? Okay, so of the 18, here it is, 18, and it's a very large percentage of the uninsured, of the young people, because there aren't that many young people in Vermont. There are a lot older a state. There are 17%, and this is the number the administration always talks about, 17% of the uninsured are 18 to 24, these young invincibles. That's only 10,000 people. But if you when I pass this around, you can see this little bar on the end. This is the percentage of people 45 to 64. It's a little bar because it's only 7% of the older people, but it's 13,000 people. 13,000 Vermonters, 45 to 64, do not have insurance. These are people who, I am guessing, dollars to donuts, know they need insurance but can't afford it. Right? I mean, how many 50-year-olds do you know who really don't think they need health insurance because their body's doing fine? It's just not happening. And those are people who aren't on insurance because they can't afford it now. And here we are with this healthcare exchange about to make healthcare significantly more unaffordable. Let me just, I'll wrap up and then answer more questions. There are two statements from this survey that just blew me away, and I want to read it. Was anyone in your family contacted by a collection agency about owing money for an unpaid medical bill? So it's not the doctor calling you, or not some friendly person. It's a collection agency, meaning that's a problem. 94,000 Vermonters were contacted in 2012 by a collection agency over a medical bill. That's a state of 620,000 people. 284,000 people said they were concerned about being able to afford prescription drugs. 285, that's almost half the state, admitted that. I mean, that to me is just a remarkable number. And another 140,000 people said there were times that they had a problem paying for a medical bill. I mean, that just gives you the level of financial anxiety that are out there for people. Now, that's all income levels, but that does paint the picture. So to me, there is simply no reason the state of Vermont should be moving backwards by raising people's healthcare costs, particularly people making under 30 grand a year. So that's the exchange, and I'm happy to talk more about it. And then after that, I would like to talk a little about single payer and how we're going to get there and where that's coming from. This also blew me away. 75% of the uninsured in Vermont are working, and of those 75% of those work full time. What that means is the uninsured are basically working a full-time job, but they either work for an employer who doesn't offer insurance, or in like a Walmart situation, you work for an employer that offers such bad insurance it's not even worth you taking it. So we do know where the uninsured are, but they're not enrolling. And what we found from the surveys, most Vermonters know about Catamount and VHAP, but they can't afford it. So to me, the question, the public education, I think we all have down. We know how to get to people, but how do you get them to actually enroll? You have to make it affordable. I think only 4% of the uninsured are above 400% of the poverty level. Most of them are under 200%. I think it's 2/3 are under 200% of poverty level. It means 2/3 of the uninsured are making less than 20 grand a year. It's probably an affordability issue for them. So how do we get them? You make it affordable. That's what I would say. I think the best thing about it is that you are finally going to see whether or where you work be disconnected from getting health insurance. Employers are going to drop insurance, and that is a very good thing. And that will make our transition to single payer a lot easier. With the minimal or zero financial penalties for dropping insurance as an employer, most employers will do the bottom line and do that, and that'll be a very good thing. After that, well, in the bigger picture, the Affordable Care Act brings tens, if not hundreds of millions of federal dollars into Vermont, which we can then use to transition to single payer. So that's good, but that's not about someone's daily life. That's more systemic reform.
If I work for an employer more than 50 employees, as an individual, I have no choice whether I can be in the exchange. It has to be, my employer has to make the decision for me.
If you work for an employer with more than 50?
I can't just jump
well,
ship
actually,
on my
that's
own.
not for any employee. Any employee who has access to employer-sponsored insurance that's defined as affordable by the exchange, which is a kind of arcane definition, but basically, as long as it meets some basic parameters, has to take their employer's insurance.
And the only way out of that is for the employer to drop everything.
That's right. Which I believe is going to happen. I believe even school districts are going to drop insurance. Now, this raises a big problem, I believe, in that, let's say I'm a union, or any employee, but let's say it's particularly union, I have negotiated through contracts this whole overall compensation package, which includes health care. And in many cases, as we know with union negotiations, you give up compensation to get a health care benefit. So in the exchange, all of a sudden my employer drops my insurance. Well, that's great for the employer. I'm getting health care, but where's my compensation? Like, I gave up a lot of pay for that. How do I get that back? That's also going to be, honestly, the same issue for single-payer health care. That's something we really have to think about. How do we make sure employees are fairly compensated for what they are losing in their overall compensation package? Another example, well, we'll go into single-payer in a moment.
But then there's less tax money, so the taxpayer has less of a
So this is a little bit tricky. we have gone to the governor and the legislature with a way to possibly fund this state RAP to make healthcare more affordable. And it is a regressive tax, but I do believe it has many benefits. It's a tax on all sugar-sweetened beverages, meaning things like Gatorade and Snapple, Monster, basically anything but juice, or 100% juice. That would raise a penny an ounce tax on everything like that, would raise $28 million a year. So not only, and we can talk about the health benefits of limiting sugar-sweetened beverage consumption, its links to obesity and a whole myriad of other things. But to me, the fact that the governor is he's opposing any new revenue, which is, that's one thing. But to me, asking Vermonters to pay 12 cents more for a can of soda is a lot better than asking them to pay thousands of dollars more in health care. I really don't see how the governor is willing to allow people to pay such high levels in their health care, but will not ask them to pay 12 cents more for a can of soda. And I don't want to make this about the sugar-sweetened beverage tax, but I do have this poster that shows how much sugar is in some of these beverages. 17 teaspoons of sugar in a 20-ounce Nantucket Nectar. Now, I just want to say, one day at the office, I took a 20-ounce bottle of water and thought, how much sugar can I put in it to see what that would taste like? And I couldn't get past 8 teaspoons. I actually got nauseous. That's how much sugar my body could handle in just water. But yet, you can drink one of these drinks really quickly. And here's two stats I want to read you from this poster. The extra calories from adding just one 20-ounce Mountain Dew to your diet without adjusting, exercise would add enough calories to cause a 30-pound weight gain. One Mountain Dew a day, doing nothing else different in your life, is 30 extra pounds of weight a year. And particularly among youth, if you're a youth that consumes this, if the average youth who consumes these beverages, 12 to 19-year-old boys consume 108 gallons a year of this stuff. Here's the one that I have kids this age, so it really rocks my world. If you're a 2 to 5-year-old, you're drinking 47 gallons a year of something that basically is all sugar with no nutritional benefit. And I could talk about how this is driving obesity, and we could talk at length about that. I don't want to bore you all to tears. But the point is, these things are unhealthy. They're being overconsumed. To me, it's a perfectly rational thing to tax if you have to fund affordable health care. What? That's right, and it's completely optional. And there is no nutritional value in any one of these products. And much like with tobacco, there are certain people who will not certain people, there's a lot of people who will not respond to public education efforts. And I have numerous dentists who tell me stories. So they come to me and say, Peter, I have people, I'm drilling their 4-year-old's teeth out already because they're rotting. And I say, do not let your kids drink this stuff. And you know what the parents do? Parents walk out with the Mountain Dew they came in, and they walk out of my office. I mean, you cannot get more direct public education than your dentist or dental hygienist saying your kid is losing their teeth. So the point is, much like with tobacco, until you raise the price point of these beverages, until you raise the price point of these beverages, you will not see a drop in consumption, much like we did with tobacco. And I believe these sugar-sweetened beverages, quite honestly, are the tobacco of our generation when you look at how damaging they are to people's health. But I also see it's a public health crisis, and it's a revenue source for affordable health care. And I believe 12 cents more for a can of soda is very reasonable compared to paying thousands more for health care.
Basically, the governor wants good health care, but he's opposing this, which will do a lot, help the teeth of young children and reduce the obesity and junk empty calories intake. So he's saying one thing and doing another. This is
Agreed.
Totally against.
Well, I'm also not sure that the governor is completely committed to providing affordable health care. When you look at the numbers in this chart, I would not argue that these numbers are all that affordable. I mean, the exchange is going to be great until you get sick.
I'm probably a minority opinion in this room, but I actually don't agree with that tax. It's not that I think that those are particularly healthy, but I think that that's a regressive tax, because if I'm making $100,000 a year and I buy a case of that stuff and I'm making $20,000, and I personally would like to see the governor I know he's against raising any taxes. I would like to see him really work on making the income tax more fair, so that people are being taxed by income, not by what they consume.
Right. I agree. I agree. And let me say, I agree with the need to raise income taxes, to make our income tax collection more progressive. I would argue that the benefit of the sugar-sweetened beverage tax, it also has a positive health impact. I could literally bury you with peer-reviewed surveys that show that by raising this tax, you would decrease consumption of these products, which would lower the incidence of many diseases. And the fact is, we had the Vermont Low Income Advocacy Council endorse this sugar-sweetened beverage tax. And the main reason they did it was that they found that so many of the diseases caused by overconsumption of these beverages are regressive, meaning lower income people have a higher prevalence of obesity, diabetes, and other.
That's a really important point. If anything targets low-income people, it's the effects of the sugar.
And I would also argue, and again, I would certainly do anything to increase the progressivity of our income tax system, but the fact is that doesn't seem to be on the table. And this is a very regressive cost increase. And if we don't have a funding source to bring this down, we are basically going to see low-income people and middle-income people pay a lot more for their health care. And to me, 12 cents more for a completely discretionary item like a can of soda is acceptable. I mean, there's a reason our coalition of groups did not choose to attach a tax to anything that had caloric value. Like even a Snickers bar actually has things that can help you get through the day. You know, nutritionally, nothing in these beverages will help you. So I understand it's aggressive, but it would actually also have a health benefit. And I don't mean to beat that dead horse there.
Well, I think the notion of 12 cents is pathetic. It's insignificant. It's not serious. Anyway, going back to what you said about 20 to 30.
Could you speak up, please?
30 to 20 products in the industry.
In the exchange.
Yeah, well, but to the insurance industry, again, it's totally irrational, but which one of them has a benefit for a wellness program?
There are some of these. These plans will have first dollar coverage, meaning free coverage for certain preventative measures like an annual checkup, which is, I'm not going to say it's tokenism, but it's tokenism. So, you know, the exchange, as my first line was, is simply a collection of private insurance products. It's the same thing we have today. There will be no massive revolution between December 31st of this year and January 1 of next year, right? It's just going to be the same collection, slightly modified collection of private insurance products with the same problems, as Maggie said, with profits built in. And until, honestly, we get to single payer, which I'd like to, to talk about, we're not going to have there's no real incentive for prevention. I would also like to add one last thing before I leave this thing about the out-of-pocket costs. There is no health professional. There is no one who works in public health that has actually said raising these out-of-pocket costs is better for people. Okay? We just got 100 and something doctors to sign a letter to the governor saying, please hold everyone harmless. There's, 30-something consumer advocacy groups working on this. The governor, through his budget process, is the only one that seems to think this is acceptable. I just want to say there's no other side. Even Blue Cross Blue Shield is not saying that this is a good thing. They know that high out-of-pocket costs do not really help make people they haven't weighed in against it, but they're not saying this is good. So just remember that our governor, through his budget, is kind of out there alone in his desire to see people pay more for health care and not less. I want to add that. Wait, she hasn't asked a question. I'm sorry.
I'm curious what's going to begin to happen during 2014 as what we would probably begin to see is more uninsured people appearing in the emergency rooms and hospitalized when we do not have the kind of plans, even like we have now. I mean, they're going to be pursued to enroll in something, and they're already saying, we cannot do this. So who's going to eat this cost? What are the hospitals, how are they going to respond to this over this time
Well,
frame?
they're probably going to do what they do now, which is rack up costs in uncompensated care, which is then paid for by people either through raising their overall budget request to the state or cost shifting it onto everyone else. I mean, maybe people will enroll. Maybe that won't happen. So one of the main concerns I have about the exchange and its impact on consumers, I actually believe that it will probably impact public support for our move to single payer. Because for the general public, I believe this is all government health care, right? You're in, like that famous line from this debate over Obamacare, government, keep your hands off my Medicare. Like, that is not so isolated. There's a lot of confusion about who gets what from where, right? And so right now you're on Catamount or VHAP, and then you're going to pay more in the exchange potentially, or you're going to have high deductibles or whatever, and that's government health care because it's the exchange, and you're not going to be able. Many people won't differentiate the exchange from single payer, and if I was the opposition to single payer, the first thing I would say is, well, look what you've got with this step of government health care. Here's the exchange. You're really going to love single payer when the government takes over the whole thing, and I believe that's why one of the reasons I'm working so hard to make this exchange work for people is so we do keep that political support going for single payer. So we had a very positive development, because I want to say something positive. I want to be positive. We had a very positive development. The governor's administration, by statute, had to release a report on how to finance Vermont's move to single payer, which begins in 2017. And they released that report in February, and earlier this month in February, and they found some really good things. That Vermonters are paying right now about $3 billion a year in out-of-pocket costs. Businesses and individuals in premiums and stuff like that, $3 billion. When we move to single payer, to replace all of those costs, we only need to raise $1.6 billion in taxes, which is really quite remarkable. When you think about single payer is going to, A, cover everyone, so that's 40,000 more people have insurance today. B, it's set in statute, so the quality of the health care is going to be better. There's going to be a better benefit package than most everyone gets today. So you get more people get health, everyone gets health care, and they get better health care. And it's going to cost half as much. 1.6 is roughly half of $3 billion. And when you hear the opposition to single payer talking about, oh, it's going to be a $1.6 billion tax, which they say from every mountain they can, they neglect to say that Vermonters will no longer be paying the $3 billion to insurance companies that pay now in out-of-pocket costs like premiums and deductibles. So to me, this is a very positive thing that I think we can build on to keep talking to our friends and talking to everyone about that. We really are building a system right now that will probably, for half as much money, provide significantly better care to a lot more people without things like waiting periods, open enrollment periods, reconciliation, getting back billed for health care you already got, and deductibles and co-insurance charges. So to me, the governor's going to, I think his administration will start talking about this more publicly. They just released a report and they're developing an outreach plan. I'm sure there's going to be public hearings on this in Brattleboro and around the state. So to me, that's very exciting for single payer. The only downside is, the only thing that scares me is the potential lackluster rollout of this exchange and how that would impact public support for single-payer health care.
How many more Medicaid enrollees do they anticipate when the new system comes in 2014?
I have that. Just give me 1 second. Well, there's about 100,000 Vermonters on Medicaid right now. And they estimate by the end of 2014 there will be 160,000 Vermonters. Yeah, there's maybe I'm not sure if Dr. Dinosaur's counted. It may be a little less, but there's going to be many thousands of more Vermonters who will be on Medicaid that are not on it now.
Patients on Medicaid have the problem of with the shifting incomes that you talked about before. They go in and out of eligibility.
Right.
And this is going to enlarge not only the workload of the people who are trying to accommodate them, but it's also going to make it harder for more people are going to be in and out of insurance at all, and that bothers me.
That's the drawback of a system shouldn't even call it, like the exchange, where you have these income levels for different programs, whereas with single payer, everyone's going to be in one program. I do believe a benefit of the exchange will be if we can do it well and consumers don't suffer too much, we will really be able to say, look, we've tried everything under the sun under this private insurance model with private insurance companies. Now there's simply no way this dog just won't hunt. It's not controlling costs. It's not letting people get enrolled. We have to move to single payer. I think after 3 years of the exchange, Vermonters will be so fed up with it that single payer is going to look even better than it looks now.
Yeah, and here's a public program that puts people in and out, which I think is disgraceful. But if they come in to sing, they should all want single payer.
They should, David.
Can you
tell us why the federal government didn't allow Vermont to get an exemption and move forward with single payer? What was the reasoning behind it?
Boy, well, the backstory to David's question is Bernie Sanders tried to put an amendment into the Federal Affordable Care Act that gives states the right to leave the exchange in 2014 and still get the federal matching dollars. And the Congress and the president did not allow that amendment in, and they put in a different amendment that allowed states to leave the exchanges only in 2017, which is why we have to wait to 2017 to begin to implement our single payer program. The why, I really don't know. It wasn't.
I didn't realize it was in the bill.
Yeah, no, it's in the bill. It certainly isn't any. It was basically meant to hold Vermont back from making progress. I mean, that's the only thing. There is no asset to Vermont. We had requested to get out of this, and they said no. So, it's federal law.
This is a follow-up question on the Medicaid
Yeah.
question. Those extra 60,000 people expected to go onto Medicaid rolls,
Right.
what are they? What do they have now? No insurance at all, or something else?
A lot of it's a mix. A lot of them are uninsured.
Yeah.
There's probably about 8,000 people right now who are eligible for zero-cost Medicaid who don't enroll for some reason. Mm-hmm. There's about, as I said before, there's probably about 25,000 Vermonters who are on either VHAP or Catamount, who because of the categorical exclusions are not allowed into Medicaid. And then, believe it or not, there actually are working Vermonters who have employer insurance, who are Medicaid, who are eligible for Medicaid.
A practical issue
Yeah.
is regarding the ability of patients to get in to see physicians.
Right.
That's a lot of new people on Medicaid, and
Yeah.
most people know that payments to
Right.
physicians is very, very low,
Right.
not even close to overhead.
Right.
So the practical thing is for physicians who are trying to survive in their little businesses.
Right.
Some of them cannot take new Medicaid patients now, so I'm concerned about accessibility with that increased numbers of Medicaid. That's a big deal. I mean, I think people should realize that. We only have, 1,200 physicians in Vermont seeing patients,
I would have to say I feel like the parts of my job when I do our hotline or talk to consumers about enrolling, one of the dirty things that I feel after I do it is I know a lot of them do not have access to a primary care physician. I'm encouraging them to enroll, but I know they're not going to be able to see a doctor, especially in places like the Northeast Kingdom, big-time primary care doctor shortage. What I'm doing, or at least I try to ease my conscience, is at least I'm making sure they have insurance so if they need emergency care, they're not wiped out, which is not what you're talking about. But I do believe that there is a clear lack of access to primary care, and that and obviously and all of us recognize the Medicaid under reimbursement issue, and this is only going to exacerbate it. The best thing I can say, I guess, is that for better or worse, more and more practices are being gobbled up by hospitals, which have mechanisms to, making doctors employees of hospitals. Not saying it mitigates it, but at least
That's right.
it doesn't make it better. It makes it a little less financially painful to a family doc. But it's a big problem, and it's the dark underbelly of this whole thing.
Correct.
And yet the backlash could be that the number of people going to ER increases because now they have insurance, but they don't have a doctor to go to. So
That's right.
they feel entitled to health care, so they're going to show up in the ER.
That's absolutely right.
Right.
No question.
And again, it's not. It's probably not something that's fixable under this private insurance exchange. I think they are. When single payers discuss, they are talking about a higher reimbursement rate for Medicaid.
Right. I think that could
and
be
that's
good, but, yeah.
and it has to happen. I mean, it has to happen.
We are right now, I think, 49th out of 50 in terms of the amount of what physicians are paid for a Medicaid visit. That's and Vermont physicians are among the very lowest paid in the country. And in terms of accessibility, an issue is are people moving to Vermont as physicians now, not knowing some of the issues that are going to happen in the healthcare delivery system. And you have physicians who are retiring. I mean, I think there are more people in Vermont right now, physicians retiring, than there are coming in. And it's a big problem. I mean, we're 50 down right now in terms of primary care in the state of Vermont, and we're probably going to be 75 to 100 within the next 4 to 5 years.
To the governor's credit, in his budget this year, he did put in, I think it was $24 million to address the Medicaid under reimbursement, anticipating that there will be. I mean, that's good, and that's that'll stop some of the hemorrhaging. It's not gonna, it'll probably stop the increase as the governor described it, because more people know it. So it probably keeps it where it is now, which is obviously not a great thing. And what?
No, but the primary care shortage is a big issue.
Richard, speak up, please.
The primary care shortage is a big issue. In the bill that, in the ACA and also in the Vermont healthcare bills that have passed recently, there's long-term solutions, but they're going to take probably a generation to play out. Loan forgiveness, if it gets advertised, it'll probably attract more primary care physicians, but we're talking really slow. It's going to take 10 years before we start seeing that. So it's not a problem. You don't go out and bring more doctors in. It doesn't work that way.
You're talking about medical students coming in, like the Fletcher Allen, medical students, and let them stay in the state and pay for their education. Right. Okay.
So let me just say there's a couple things I'd like you to think about or to do as you walk away. One, since it's 8:15 and I think maybe people are winding down. One is, when you talk to people, please make sure to differentiate the exchange from single payer. Don't let people confuse the two, because that's really going to be damaging to our end goal. Make sure that people do not think Obamacare is the end goal in single payer. And the second thing I would ask you, if you can, is to think about weighing in either through a letter to the editor or contacting me, contacting a legislator, about a state subsidy that would actually make the exchange affordable for people. Because it's not good enough, as the governor says, to wait for 2017 in affordable health care with single payer. I mean, people have to live today. There's this great quote from this man, Harold Hescock, who worked for FDR, and it was a problem in a New Deal program, and one of the people said to him, well, we can fix that problem down the road. And this very wise man, Harold Hescock, who worked for FDR, said, people don't eat down the road, they need to eat every day. And that's how I think about this exchange. People cannot wait 3 more years to get health care through single payer. They need to get health care every day, which is why this exchange has to work in terms of affordability for people. So if you've signed a list, and Richard can get in touch with you, or I can give you my email, whatever, but please think about weighing in about the need for public dollars to go to subsidize people in the exchange. As distasteful as it may be to give more public dollars to insurance companies, in the end of the day, it is about consumers getting care they need at a price they can afford. So I'll hang around, answer questions, and thank you so much for having me.